So in this video, we're going to continue with cardiovascular pathology. So the first thing we're going to talk about is cardiac arrest, and that literally is the cessation of heart activity. It's the flat ECG. It is the heart not contracting. There's no system happening. It could be because of cardiogenic shock, excessive parasympathetic stimulation, so vagal stimulation. Could be electrolyte imbalances, specifically potassium. Could be a blow to the heart, that kind of thing. Okay, heart failure is not the heart stopping beating, but a loss of contractility to the point where the heart's unable to pump sufficient blood in each stroke volume to meet the demands of the body. It's often a complication of something else, and then we try and compensate for it. Sometimes the compensations end up aggravating the problem. It's often a problem. And we call it congestive heart failure because if the stroke volume of that ventricle goes down, then the amount of blood that stays in the ventricle increases. And that means that the blood from the atrium can't empty into the ventricle. So it backs up. It backs up into the atrium. And when the atrium is full and can't empty into the ventricle, then that backs up into the veins that enter that atrium, and we end up with congestion from that. It's just really a backup. So it's stroke volume decrease, which is also cardiac output decrease. It means that moving forward, there's less blood being pumped out to the various organs, which leads to inadequate oxygen delivery, which leads to not enough ATP, which leads to fatigue, lethargy, and that kind of thing. It also leads to acidosis. The carbonic acid builds up from the CO2 because that's not being pumped to be gotten rid of, right? So the congestion gets worse when this happens, right? So the output of the stroke volume is less than the input, and so congestion backs up. And it backs up into the veins, whether the pulmonary veins or the vena cava, it backs up into the veins, depending on which side of the heart is having the failure. So if it's the left ventricle, for whatever reason, loses its contractility. It can't empty. That means the blood backs up into the left atrium. The output into the aorta is decreased, which means there's less oxygen and blood getting to the kidneys. So the kidney will respond with the renin, angiotensin, and aldosterone secretion to try and increase the amount of blood and cause vasoconstriction to increase blood pressure to make up the difference. But all that ends up doing is it backs up the blood up into the pulmonary vein, because when output is compensated for, the input to the heart stays normal for a while, and then it congests in there. It backs up the pulmonary vein if it's the left side, right? And then the high pressure in the pulmonary on the pulmonary side leads to pulmonary congestion, edema within the lungs itself, because there's no place for the blood from the right side of the heart to go. So the pressure increases and fluid leaks out, and we end up with pulmonary edema. So the left side backs up to the lungs. On the right side, if we have the right ventricle getting weak, then it backs up into the right atrium, which backs up into the vena cava and into the entire venous side, right? And so that becomes the problem. The output to the pulmonary arteries is decreased, so less blood goes to the lungs, which means that there's less blood going to the left side, which then decreases cardiac output on the left side, which causes the kidneys to do the renin-angiotensin. So the arterial side of congestive heart failure is the same whether it's left-sided or right-sided. It means that there's less cardiac output to the system, and the kidneys respond with renin, angiotensin, and aldosterone secretion to try and raise that blood pressure. The left side backs up to the lungs, and we end up with a pulmonary congestion. The right side backs up into the systemic veins, and we end up with edema all over the place, but especially in the lower limbs and in the head and neck. So you end up with cerebral edema and distended veins in the neck because there's too much pressure in the veins. So the forward effect, the same on both sides. Decreased blood supply to the tissues, hypoxia, fatigue, weakness, dyspnea, shortness of breath, compensated with tachycardia, vasoconstriction because of the renin-angiotensin and the kidneys getting involved. And then the kidneys suspend making urine, and so you get oliguria, that that's not enough urine. Toxins build up, etc. The backward for the left is pulmonary congestion, difficulty breathing, cough, right? Difficulty breathing, especially at night when you're laying down. The excess fluid can lead to pneumonia and those sorts of things. Lung problems, in short. On the right side, the backup is systemic. So you end up with edema in the feet and legs and increased pressure in jugular veins, in the neck and head. You end up with the blood backing up to the liver. So the liver enlarges, the spleen enlarges because of it. You get ascites, which is making too much fluid in the peritoneum, and the abdomen fills with fluid. Distended neck veins. Cerebral edema gives you headache, visual disturbances, especially if the edema gets bad. The occipital lobe gets crushed, and you end up with severe visual disturbances from it. So this chart sums them up. Left side could be an infarction in the left ventricle, aortic valve stenosis, hypertension, so too much afterload, so cardiac output goes down, that kind of thing, hyperthyroidism. You end up with a decreased cardiac output and pulmonary congestion. Forward gives you fatigue and weakness, cold intolerance, compensated with tachycardia and maybe some polycythemia because the amount of erythropoietin goes up because the kidneys aren't getting enough oxygen. The backup effect is difficulty breathing, cough, maybe coughing up pink-tinged phlegm, shortness of breath, coughing up blood, that kind of thing, pulmonary congestion. On the right side, it's something like an infarction on the right ventricle, a stenosis in the pulmonary valve, whatever. You get decreased cardiac output, edema in the legs, abdomen, in the neck veins, headache, cerebral edema, that kind of thing. Backwards, compensated with tachycardia, secondary polycythemia, fatigue, weakness, dyspnea, cold intolerance. So the forward effects and the compensations are the same. The backup effects are the things that are different. Sometimes kids, like babies with congenital heart defects, end up with congestive heart failure. So generally, this is figured out because of the congenital defects, and we'll just kind of leave it at that. Okay, there's a bunch of congenital heart defects. We look at cyanotic versus acyanotic events. If the blood is moving inappropriately from the right side of the heart to the left, it's cyanotic. The left or the right side has got deoxygenated blood and it goes into the left, and so you have cyanosis. If the shunt goes the other way and it goes from left to right, it's oxygenated blood that's being inappropriately put into the right side circulation, and we don't have cyanosis, so it's called acyanotic. So that really matters. Generally, congenital heart defects develop fairly early. Now, they don't amount to a lot fetally because fetal circulation bypasses the whole pulmonary side, and there's supposed to be a shunting right to left through a septum, a hole in the septum at the foraminal valley, and through the ductus arteriosa, which is a blood vessel that joins the pulmonary artery to the aorta. When the baby's born, however, and takes its first breath, then the dual nature of circulation kicks in and the problems become apparent. So if the large defects are there, then we have a problem of pallor in that there's not enough blood circulating to do the job, tachycardia to try and overcome it, difficulty breathing, especially on exertion, club fingers, which is a sign of chronic hypoxia, intolerance for exercise and cold, delayed growth, and it's all because of a lack of supplying oxygen to the tissues. If there's small defects, they may not be detected for a long time. I had a roommate in chiropractic college that found out that he had a heart defect. He had a patent foramen ovale. So the fossa ovale didn't close when he was born, and he was having an opening between his left and right atria. And he was 27 years old before they found this out. He played hockey, he was an athlete, so it was a very minor thing. But nevertheless, it had to be surgically corrected. so that it didn't give them problems into the future. So a lot of times these things are subtle and really silent if they're minor defects. They find them with different diagnostic imaging, CAT scans, PET scans, things like that. Oftentimes they're found as artifacts to another investigation. If it's bad enough, they can pick it up on the electrocardiogram or echocardiograms. And usually it requires surgical repair because these are defects in the walls of the heart. So the one of the most common is something called VSD, ventricular septal defect. And this is really an opening between the left and right ventricle in the intraventricular septum, right? It usually is quite small, but it varies in size and locations. Because the walls of the left ventricle are so much thicker, the myocardium on the left side is much, much thicker than the right side. There's more pressure in the left ventricle, which means that when the left ventricle, during systole, the left ventricle is producing so much more pressure that the blood, the oxygenated blood, squirts from the left ventricle into the right ventricle through this opening. Right? So that's acyanotic. It often is fairly silent if it's a small hole. It doesn't matter a lot unless there's a lung problem. And if there's a lung problem, then what happens is the pressure on the pulmonary side goes up. And if the pressure backs up into the right ventricle, it can cause problems. It can push blood the wrong direction, really. So they used to do complete open heart surgery to repair the thing. Now they seem to be able to put like a scope in and do it with a catheter or some hybrid procedure from that. Right? They use different meds to keep the contractility of the heart up and keep a regular heartbeat if necessary. Okay, another problem, very common, is problems with the valves. This is what causes murmurs when people listen, auscultate with a stethoscope. You hear these murmurs, and those are really valvular problems. So often it's the aortic or pulmonary semilunar valves that are affected. Although you can have mitral valve or tricuspid valve issues as well. So kind of all four. There's one of two things goes on. Either the valves don't open enough and so the opening is too narrow, which is a stenosis, or it's valvular incompetence, in which case the valves of the don't close, the leaves of the valve don't close enough, and we end up with incompetence or regurgitation. The door doesn't completely shut. A problem of mitral valve, and oftentimes this one needs to have a surgical intervention because the left ventricle pressure is so high that what can happen is it can push the mitral valve, the bicuspid valve, right backwards and blow it out backwards, and that's called a prolapse. It can stretch out the leaflets of the valve. It can do that kind of thing. Normally, when this happens, they do a valve replacement. Mitral valve seems to be the most common valve replacement. So they either put a mechanical valve in it, which is really a little cage with like kind of a small ping pong ball in it, uh, and it closes off when during systole, prevent blood from going back into the atrium. Uh, but lately, they've been able to use pig valves from a pig's heart, because it's entirely connective tissue. There's not very many cells in it. It's mostly extracellular collagen fibers. It evades for the most part, it evades the immune system. So the transplantation of these parts are reasonably easy. When I was in high school, there was a good friend of mine. His father had a mechanical mitral valve replacement, and you could hear it click. we used to uh, we used to like seeing him get mad or excited because you would actually hear the valve closing. You're like, right, you didn't need a stethoscope. You'd hear this click, 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 click. Um, that, of course, as 15-year-olds thought it was hilarious. So, in a normal valve, when the pressure on the one side is higher than on the other, the valve opens and blood just flows through. So this is the atrium, this is the ventricle. During diastole, during the filling part of diastole, the blood flows through, the valves open. During systole, the pressure in the ventricle pushes back, the valve closes, blood doesn't go backwards. In the case of stenosis, the valve doesn't open enough, and it's difficult for the ventricle to fill during diastole because of the narrowed opening. But during systole, the valve closes and works normally. So the problem with stenosis is not enough filling. So stroke volume goes down because end diastolic volume goes down. The incompetent valve is when the valve opens freely and you have adequate filling during diastole, and diastolic volume is good. But the problem is during systole, the blood is regurgitated from the ventricle back into the atrium because the valve didn't sufficiently close. And so the blood, instead of going out the aorta or the pulmonary artery, goes back to the atrium, which then means that the atrium doesn't fill enough and the cardiac output, the stroke volume out of the ventricle, goes down because blood is lost through that valve. What ends up happening then is that the walls of the heart have to increase their contractility to try and overcome this problem. And if this is mitral valve, then what happens is the walls get big and you get left ventricular hypertrophy, even though you still have decreased cardiac output, right? And the atrium doesn't empty, and so this backs up to the lungs, to the pulmonary, a lot like congestive heart failure. Another problem with this ventricular hypertrophy is the walls grow inwards, they get thick inwards, which makes the space, the lumen of the ventricle smaller. So there's less room to fill, so cardiac output goes down in that case as well. So mitral valve replacement. Okay. There is a defect. It's congenital. It happens at birth. That is a cyanotic defect. So what happens, it's called the tetralogy of Fallot. Tetra means there's 4 things wrong. And it is a right to left shunt, so cyanotic. Pressures in the heart get screwed up and there's altered flow. There's 4 abnormalities, right? One of them is a septal defect in the ventricles. And the aorta moves over and the right ventricle has to pump into systemic circulation. The ductus arteriosa often stays enlarged. Okay, I've brought in some slides from the other slideshow, the supplemental notes slideshow that I posted for you, to look at these heart defects because there's better pictures in this particular slideshow. So the acyanotic are left to right shunting. So the atrial septal defect, ventricular septal defect, patent ductus arteriosa, coarctation of the aorta, and pulmonary and aortic stenosis. So it looks like this. The atrial septal defect is supposed to be there when in children, in pre-birth, so in fetuses. It's the foramen ovale, and then it doesn't close in some. So you get an increase in pulmonary flow. It can lead to pulmonary hypertension and right ventricular hypertrophy because it's got to push, because there's more blood coming. Because not only is it the blood from the vena cava, there's blood from the left atrium comes in. That's what Brent had. A ventricular septal defect is this, which I've already just talked about. The left ventricle, blood flows out, and pulmonary hypertension and right ventricular hypertrophy, again, for the same reason. A patent ductus arteriosa is normally in fetal circulation. Blood from the right ventricle goes out the pulmonary artery, and then it passes through into the aorta because a fetus doesn't use their lungs. This turns into a ligament shortly after birth. The problem is that if it stays open, then the pressure in the aorta is so much higher than the pulmonary artery that blood goes this way through, and the pulmonary artery gets too much blood and it gets too much pressure, so you get pulmonary hypertension. And it becomes a problem of afterload for the right side of the heart, and so the right side of the heart may not be able to overcome this pressure. Coarctation of the aorta is a narrowing of the aorta here, right? And this means that blood has more difficulty getting out, and pressure backs up, and it leads to hypertrophy on the left side. Pulmonary stenosis, or just being missed, is difficult. So if it's on the pulmonary side, the blood enters the lungs by traveling through the septal opening and the ductus arteriosa because the pulmonary artery is closed. If it's atresia, there's no valve. If it's stenosis, you have difficulty opening the valve cusps. Aortic atresia is not compatible with survival, so we don't see those in living people. The cyanotic goes the other ways. The tetralogy of Fallot is this. So you get the ventricular septal defect, right? The aorta is positioned over this opening. So the aorta has moved over here, and it's kind of half in the left and half in the right ventricle. You get pulmonary stenosis, usually because of the pressure of the aorta being pushed over here, and you get right ventricular hypertrophy because you're trying to overcome the stenosis of the pulmonary side. So what happens is the blood on the right side pushes over to the left here, and that's why it is cyanotic. This needs to be surgically repaired as soon as possible. Sometimes you get transposition of the great arteries, in which case the aorta ends up coming off the right side and the pulmonary comes off the left. But the problem then is that the blood circulates through the lungs to the left atrium, to the left ventricle, back out the pulmonary artery, back to the lungs, and the blood on the right side goes out the aorta through the arteries and the capillaries and the veins, comes back in the vena cava, and this way. So what ends up happening is both sides of the circulation are independent of one another. This is not compatible with life for very long, unless there is a patent ductus arteriosa, if there's an atrial septal defect, then maybe life will be possible until there's surgical correction is allowed. Now, the atrial septal defect and the patent ductus arteriosa are normal features for the fetal heart. So these people go full term and are compensated because you really don't use the pulmonary circulation when you're a fetus. It's not until you start to breathe. So that can be, that is a major problem. That's not compatible with life for very long. We can now surgically correct it. Okay, so we're back to the original slideshow. Okay, so that's the tetralogy of Fallot. So there's the patent ductus arteriosa. There's a ventricular septal defect. There's an atrial septal defect here. Both of these being acyanotic. Coarctation is here. This one is the transposition of the great vessels, which it's considered a cyanotic because deoxygenated blood goes out the aorta. And this is the tetralogy of Fallot here. Okay, inflammatory and infectious problems of the heart. The biggest one is rheumatic fever. And oftentimes, this is mistakenly thought of as a streptococcal infection of the heart. It's really not. people get a streptococcal infection someplace, like strep throat, and it's left untreated. And so beta hemolytic streptococcus gives you strep throat. And what happens here is the problem with beta hemolytic streptococcus is that the antigens on the surface are remarkably similar to collagen. So as your immune system is attacking the strep, it creates antibodies that start attacking collagen. And so it becomes an autoimmune attack on collagen-rich organs in your body. That's why it's rheumatic. Rheumatic really means autoimmune. So it happens in the joints, especially around the ligaments and things like that. And the valves in the heart are big problems. Sometimes it's the dermis of the skin. We call that scarlet fever or rheumatic fever. Rheumatic heart disease is kind of a subset of rheumatic fever. Now, the problem here then is that this autoimmune attack on structures within the heart cause inflammation, and you can end up with an endocarditis from that, and it can lead to full-on congestive heart failure. So in the acute stages, you have inflammation, often pericarditis, sometimes myocarditis, usually endocarditis, and an attack on the heart valves, which then causes incompetent valves. The valves don't close because they're inflamed, and so you end up with regurgitation and valvular failure, especially at the mitral valve, because that's the one that has to put up with the most pressure. It will attack especially the large joints that have a lot of collagen in them. It attacks the skin and causes problems in the skin, which is like a red blotchiness in the skin, which is erythema marginatum, right? The inflammation will cause deposits of nodes around these places in the skin. It also can cause something called Sydenham's chorea. Chorea means dance, and it is a neurological thing where there's uncontrolled jerking of the arms and legs and face that is caused by this autoimmune attack. Now, the Sydenham's chorea is a fairly rare, like I don't even know if it's 10% of cases. But yeah, it's entirely possible. You get low-grade fever, leukocytosis, usually from post-infection. You feel like crap, anorexia, fatigue, tachycardia because of the inflammation. The valvular problems lead to murmurs. They may correct themselves, but you can hear like the regurgitation in the mitral valve. So it goes lub, dub, lub, dub, lub, dub, that kind of thing. Nosebleeds, which is epistaxis, and abdominal pain. Oftentimes there's edema into the abdomen. So we look for elevated antibodies. We look for heart function, that kind of thing. So the best thing to do is treat any strep throat you have before any of this develops. So antibacterial agents. If it starts to happen, then strong anti-inflammatories, usually steroids, so things like prednisone are used. So here we go. So you have this group A beta hemolytic strep. You get over it because your immune system has attacked it. You make the antibodies against it, but now the antibodies start attacking the collagen, which causes inflammation of the heart and the joints and the skin and the brain right? So the inflammation causes pericarditis. The fluid over in the pericardium builds up, endocarditis and valve damage, maybe myocarditis and arrhythmias because of a change in the environment, and sodium levels and that kind of thing. If it goes on long enough, you end up with scarring, especially in the valves, which leads to loss of valve function, and maybe stenosis or maybe valvular incompetence, and you need a valve replacement. All of that is rheumatic heart disease. If it's in the joints, it's a rheumatic arthritis. If it's in the skin, it's scarlet fever, things like that. Okay, this is opposed to infective endocarditis. Infective endocarditis is when the strep or the staph actually gets into the heart itself, right? Uh, so it's got something to do with a bacteria in the blood. We see this in people that are immunosuppressed uh, or fatigued or stressed, but stress makes you immunosuppressed, that kind of thing. So these are infections within the the chambers of the heart. You get fever and fatigue, anorexia, congestive heart failure if it affects the myocardium. Uh, if it's acute, you get a sudden onset fever and chills and drowsiness because it's an infection. If it's subacute, it might be more insidious. You end up with a cough and difficulty breathing because you will end up with a little bit of congestion that backs up to the um, lungs. Uh, you have to culture the blood and find out what it is and use antibiotics, and usually strong antibiotics, IV, because the problem is you don't want scarring because that leads to long-term problems, especially valve problems. Okay, pericarditis is around the heart, right? It's inflammation of that space, the pericardial sac uh, and the space between the epicardium and the pericardium. Uh, it's usually got something to do with something else, like secondary to heart attack or rheumatic fever or lupus or cancer or infections or trauma like a car accident. Anything like that can cause inflammation of the pericardium and effusions. And so the biggest problem with the effusions in the pericardium is that the liquid builds up and kind of muffles the heart, but it puts pressure on the heart from the outside, which means the heart doesn't get to fill near as much. Uh, and so it kind of leads to heart failure and the signs and symptoms that we saw in heart failure because cardiac output goes down because there's less filling during diastole. So the space of the pericardial cavity fills up with fluid and compresses the heart wall, and then the heart can't expand to fill. And so then that backs up, usually both sides, into the lungs and into the systemic side. So the vena cava and back to the lungs. And we get decreased cardiac output to the body. So you cough, you're tired, you're not making enough ATP because of low cardiac output. If this goes on long enough and we start to have histological change, it becomes a chronic pericarditis. And the biggest fear of this is adhesions between the pericardial membranes, scarring. Sometimes it's from infection, tuberculosis, that kind of thing. Sometimes it's radiation, especially people that are getting radiation on lung tumors and that kind of thing that are close by. You end up with this reduced cardiac output, a chronic reduced cardiac output, fatigue, weakness, venous congestion. So it backs up often to the right-sided failure first, because the right side of the right ventricle is much weaker than the left ventricle. So things are noticed first on that side. Okay, let's change gears completely. Vascular disorders. So this is not problems of the heart, this is problems of the blood vessels. Uh, Hypertension is a very common thing. High blood pressure. Uh, we talk about the systolic and the diastolic, or some combination of both. But hypertension, huge problem, very common in a lot of different people. So if the hypertension itself is the problem, we call this as primary or essential hypertension. The systole is high and the diastole is high. It means that you get arterial vasoconstriction. And the biggest problem here is damage to the arterial walls. So then you end up with ischemia, especially in the periphery. That can even lead to necrosis, a loss of function. Ischemia to a lot of places. Secondary hypertension is when the high blood pressure is due to another disease. Oftentimes, it is some sort of an endocrine malfunction. Pheochromocytoma is one that can cause this, and it's a benign tumor of the adrenal gland, the adrenal medulla. And what it is, it's a tumor, it's not metastatic, but the tumor starts pumping out epinephrine in an unregulated manner. So literally, people have an overproduction of the sympathetics. And one of the things about sympathetics is vasoconstriction, which increases blood pressure. So that's the sort of thing that can happen. But it's probably way more common for people to have hypertension because of renal disease. The kidneys, as you may recall, are the main organs that regulate blood pressure through the renin-angiotensin system and through the composition of blood and the amount of fluid that's in the blood. Both those things, the kidneys are involved with maintaining blood pressure. If there's kidney disease, you will end up with a secondary hypertension. If you go to a dialysis unit, I guarantee you everybody in the dialysis unit will be on a hypertensive medication. They'll be on blood pressure pills. If it is rapidly progressive, we call it malignant hypertension. So diastolic pressures get extremely high, and this is an emergency situation. Really, it's secondary hypertension from kidney disease, from diabetes, or from endocrine diseases like hyperthyroidism, things like that, or primary, where it is essential hypertension, are the ones that you're going to see. So when the kidneys get less blood flow, because of problems with the kidneys like nephrosclerosis or diabetic nephropathies. The decreased blood flow causes an increase in renin, which causes renin-angiotensin and vasoconstriction, which increases the increases peripheral resistance, so increases blood pressure. Aldosterone is secreted because of renin-angiotensin aldosterone. Aldosterone makes you reabsorb more sodium, which changes at the kidneys, which changes the osmosis, which means you reabsorb more water, and the blood volume goes up, which increases the amount of pressure, right? And when the pressure is increased for any length of time, you get damage to blood vessels in the retina, and you can go blind. So diabetic retinopathies happen because of it. You have damage to the arterial walls, so it leads to atherosclerosis and potentially heart attacks or problems of in the brain, stroke, uh, damage to the cerebral arteries that cause stroke. Right, the heart has to work harder to overcome that blood pressure that after uh, the the pressure, so it decreases cardiac output, so you need to increase contractility to get over the afterload, which causes ventricular hypertrophy and maybe congestive heart failure especially the left side. Uh, you get damage to the renal blood vessels, which actually makes the whole problem that the kidneys worse and becomes a positive feedback to that and makes the whole thing worse. You end up with a systemic vasoconstriction to compensate for the left-sided heart failure, and that renin angiotensin that's going on here for vasoconstriction, which decreases the blood flow to the kidneys. And so this whole thing is a very difficult cycle to break. So hypertension is silent usually at first, and then we get this deterioration. It affects the kidneys, the heart, the brain, and the retina, not necessarily in that order. But think about the number of people in our society that have high blood pressure for whatever reasons, and then correlate that with the incidence of kidney disease and heart disease and loss of eyesight and like macular degeneration and that kind of thing, and brain issues. If if not full-on strokes, then transient ischemic attacks, uh, vascular dementia, that kind of thing. These things usually take time to develop. The hypertension causes this damage in a slow, progressive way, and so the symptoms don't often show up until you're older, and it increases with age. Men more frequently than women. Uh, Women catch up after middle age, especially postmenopausally. It runs in families. Uh, Too much salt, too much alcohol, obesity, smoking, stress, all are factors that lead to this. It is really an epidemic in North America right now, hypertension, and these problems around it. The lifestyle choices involved with smoking and alcohol, and you know, maybe they counteract stress. I don't know. It's a complicated thing. So here's just a picture of all the things we just talked about. like I say, early stages, it is vague, nonspecific, fatigue, malaise, headaches in the morning, right? Uh, so it's easy to diagnose because you just use a sphygmomanometer. You take a blood pressure cuff and you see the blood pressure is high. If it, if it persists, then you intervene. So the first thing they tell you is you got to get more sleep. You got to cut down on your drinking. You got to reduce your sodium intake. You got to lose weight. You, you maybe start meditating, or you need to reduce your stress, that kind of thing. And then they introduce drugs. So there's a couple of different types of drugs that are used for hypertension. Your pharmacology courses will cover those, but basically make you pee more and you'll have less liquid, so blood pressure goes down because there's less blood in the same size pipes. Diuretics. Angiotensin converting enzyme inhibitors, so ACE inhibitors, are quite common, and what they do is they prevent. So renin converts angiotensinogen to angiotensin 1, and then angiotensin converting enzyme converts angiotensin 1 into angiotensin 2, which then causes the release of aldosterone to increase sodium and water intake, and causes vasoconstriction to increase blood pressure. So ACE inhibitors work directly on the renin-angiotensin aldosterone system. A third thing is to try and decrease contractility of the heart, especially to lower the systolic blood pressure. So that would be things like heart drugs, beta blockers, that kind of thing. Oftentimes, it takes a combination of these sorts of drugs to be effective. Okay, next topic is shock. Shock is a rapid decrease in blood pressure. The blood pressure drops suddenly. It can happen for a number of reasons. One is you've lost blood. So if you're hemorrhaging, you end up in a hypovolemic shock. So the volume of the blood decreases through desanguination. It could be maybe not desanguination, maybe it's massive burns and the liquid is going into the blisters. But whatever, you've lost circulating blood volume, hypovolemic shock. It rapid decrease in blood. Another one is cardiogenic shock. And this is when the heart doesn't provide adequate cardiac output. And it's the cardiac output that causes blood pressure. So if there's a myocardial infarction or something along that line, the heart fails and blood pressure drops, and this is called cardiogenic shock. There's a couple of other types of shock. There's distributive, there's vasogenic, there's neurogenic, there's septic, and there's anaphylactic shocks. So this is somehow changing the resistance of the blood vessels that then cause the pressure, the delta P, to stop or to drop significantly. So the hypovolemic and the cardiogenic we've discussed. The vasogenic is a distributive, so it's either neurogenic or distributive. So this is vasodilation because of a loss of sympathetic stimulation of the blood vessels. This can be caused by pain. It could be caused by fear, spinal cord injury, or too much insulin, so hypoglycemic shock. Anaphylaxis is really an allergic reaction, so you get massive vasodilation because of a body-wide systemic inflammatory response, anaphylaxis. So this is usually it's bee stings or nut allergies or shellfish allergies, that kind of thing. Drug allergies can cause anaphylaxis that cause massive amount of histamine, which causes vasodilation. And so the pipes just get bigger with the same amount of blood, so the pressure drops. We fight anaphylaxis with epinephrine. That's what an EpiPen does. And that causes massive vasoconstriction to offset this. The endotoxic or septic shock is when there's an infection, usually bacterial, or multiple infections from a number of different microorganisms, end up in the blood, and it causes a inflammatory reaction in the walls of the blood vessel, which then causes vasodilation, which causes a rapid decrease in blood pressure. Shock. So when you first start to feel it, your blood pressure drops, tachycardia will be probably the first thing that happens to try and compensate. The heart will beat faster to make up for the loss of pressure. You will feel that, and it will give you anxiety, which will also then cause more tachycardia because anxiety is really a systemic. It will cause vasoconstriction as well. You stop sending blood to your skin because if you don't have enough blood pressure, then why waste blood on organs that can do well without blood for a long time? So you end up with pallor, right? And sweating because of that. Oftentimes there's lightheadedness, especially like orthostatic hypotension, like getting up quickly. It leads to syncope, not only lightheadedness, but maybe passing out, right? You don't waste fluid on creating urine, so you end up with oliguria. Oliguria, not enough urine. So then you compensate. You have the sympathetics kick in. You increase the amount of epinephrine because of the sympathetics and the adrenal gland, which increases heart rate, increases contractility, and causes systemic vasoconstriction. The kidneys not getting enough blood means that renin is secreted. The brain will cause the release of antidiuretic hormone, which makes you not pee. You'll secrete glucocorticoids. It's cortisol because this is a stressful situation. You increase your blood sugars so that if less blood is getting to an area, then let's maximize the sugar content. One of the problems is that you don't adequately take away carbon dioxide, so you end up with an acidosis. Waste products not removed, so that's primarily carbon dioxide, carbonic acid, so you would end up with a lower pH and acidosis from that. If you don't have enough blood pressure, especially like for the hypovolemic shocks, then you shut down blood to the skin first, and then to the digestive system, and then to the extremities. And if it goes on long enough, to the kidneys. So you end up with kidney failure. Can end up with respiratory distress syndrome because you're not able to pump enough blood. You're not be able to perfuse to the lungs. So therefore, ventilation ends up as a problem. Liver failure, again, because of an ischemia. You're not going to send blood to the to your digestive system, which I've already said. So you get paralytic ileitis. So you stop having the contractions through your intestines and moving food along. You can end up with ulcers hemorrhaging, again, because of ischemia, maybe infarct. You're not moving white blood cells, and the immune system starts to malfunction, and so you can end up with infections, right? The stasis of blood can start causing coagulation, and you can get a disseminated intravascular coagulation, which then starts out with thrombosis and then ends up as a bleeding disorder that we talked about earlier in this slide presentation. Cardiac function is down because not enough ATP to run the heart. So early, it's anxiety and restless. You get tachycardia and thirst happens because you're trying to bring in more liquid to raise the blood pressure. Lethargy, weakness, metabolic acidosis, and then the sympathetic nervous system kicks in. So it starts out thirst and tachycardia, anxiety, which is really easy to pass off as symptoms of something else, then like a panic attack, that kind of thing. Progresses to weakness and cool, moist skin, blood pressure dropping even further, rapid breathing, rapid shallow breathing, rapid heart rate, metabolic acidosis, kidneys start to shut down. And then when it decompensates, there's not enough going to the brain, so you get confusion and stupor, arrhythmias and weakness in the heart because of a lack of ATP. The metabolic acidosis builds up even more, acute respiratory distress, multiple thrombi, and maybe even DIC, liver failure, renal failure, ileitis, gastrointestinal hemorrhaging. The whole digestive system can really be severely impaired. So that's it for this slide presentation.